Hi folks, this is Brandon Pounds again. We're working on the second portion of our Cat 3 video. We've already done all the preliminary testings and we found that her right leg is a short leg side, and now we're just kind of following up for the second portion of the video. The point of the Cat 3 is for the Cat 3 blocking is to reduce pain for that patient, and then we won't block any more than 30 minutes at a time. So like I said, we've decided that the right leg is a short leg. So we're going to treat that as necessary using our wonderful blocks. We're going to use these as of now. So for the long leg side, what we're going to take the block, and I can passively move her leg here and rotate it out. If she would just put her hands down by the side and just kind of relax, perfect. So we're going to start at the ASIS and move obliquely inferiorly. We're just going halfway in because I don't want to. We don't want to treat anything we don't need to treat. So there's that, the ASIS. Now on the short leg side, we're going to take the block, we're going to put it inferior obliquely right at that greater trochanter area. Okay, perfect. So at this point in time, we'll ask the patient if there's any reduction in pain, and if there is not any reduction in pain, on the short leg side, we're going to kind of moderately move and wiggle the blockings until there is no pain for that patient. And once there is no pain, we'll allow the patient to sit, relax up to 30 minutes until the pain has been removed. So the next step is going to be our posterior iliofemoral ligament. What we're going to do is we're going to test the patient by internally rotating the foot. So we're going to externally rotate her foot here, and we're going to find which one has a lack of rotation. We can see that her left side is the one that's the problem side is just not externally rotating. So it means we have tenderness on the posterior iliofemoral ligament. So we come over here to the acetabular joint, and I'm just going to thumb in here for that ligament, and I'm finding it right here, and all we're going to simply do is flick it. And we're flicking to the opposite greater trochanter. Okay? So we'll come back over here, we'll retest the patient again, boom. Now they're equal. If they were not, we'd repeat that test again until that patient had equal external rotation on that side. Okay, now for our next step is going to be dealing with the actual rotation and inferiority of the spines involved. Now, as I said, we already did the gluteal fiber analysis test, and we found that point number 4 was her most tender side. As we know, that's going to correlate to the lumbar, our fourth lumbar. So what we're going to do is we're going to work on that. So we're going to come here, find top of the iliac crest, coming over, we're right on L4 right here. So what we're going to do, I'm going to palpate that. And it's very obvious that spinous is rotated to the right. So what we're going to do is we're going to stand on that side, walking clockwise around the patient. So I'm going to take the patient's knee, we're going to bend it up right here, and so since the spinous is rotated to right, we're going to move the spinous into the direction of correction, hold that position right there, and as we hold it, we're going to hold that for 5 seconds right there. So 1, 2, 3, 4, 5. We'll relax. We'll repeat that same process 2 more times. 1, 2, 3, 4, 5. And like I said, we're moving that spinous into the direction of correction. So it's rotate to the right, we're pushing it lateral medial, moving it back to the left. Here, one more time. 1, 2, 3, 4, 5. Okay, awesome. Now we're going to check for inferiority of that spinous. So it looks like, and it feels as though the TVPs are superior on this right side, and it's gone superior that way. Okay, which means is on the left side right here. On the left side right here is going to be the side that we're going to push superiorly. Okay, there's the spinous. So we're going to take the same steps, bring it here. Okay, and as I bring it in, she's going to breathe in and then breathe out and hold. And as that happens, I'm pushing it I to S, holding for 5 seconds. And we're going to repeat that 2 more times. Again, breathe in, and then breathe out, and hold. Again, I to S, fixing that inferiority of that. Good. One more time. Breathe in, breathe out. Good. 5 seconds right there. Awesome. Very, very nice. Okay. Now, our next step is going to be our acetabular goading. And what's going to happen here is there's still pain on the sciatic side. So she's saying that the left side is where she's having some sciatica and acetabular pain. So all that's going to happen is we're going to take the knee. We're going to first internally rotate the hip. Okay, right around the acetabular region. We're going to find out where those trigger points are and where that kind of pain is. And she's having some pain. Is that painful right in there?
Yeah.
So that's the pain. So what we're going to do is we're going to work at that trigger point right there, applying some pressure, and then she's just going to breathe in and out. Good. And you can feel that trigger point kind of release. Now we'll externally rotate the hip, working that same region, palpating for that tenderness. She's a little tender right there? Yeah, so it's tender right there. So just breathe in and breathe out. Very nice, very nice. Okay, I can come out there a little bit. Okay, so that's our acetabular goading. The next step is going to be our orthopedic one. Now, what we did say, we said the spine is rotated to the right. So I'm going to go to the right side and voila, that's orthopedic rotation there. So what happens is, as the hip drops down, the spine is going to rotate back to the left. Okay, so it's going to rotate to the high side. And we'll hold that for 3 to 5 minutes. That'll be her, that'll complete that process. Now, we're going to do the sciatic traction and the assisted sciatic traction. So we said the left side was the side she's having sciatic pain in. So what we're going to do is, I'm simply going to grab her feet, not bringing it superiorly, because if I do, that's going to exacerbate that piriformis syndrome, causing sciatic pain in her leg. So we're going to traction her leg, S to I, hold for 5 seconds, and we'll relax. I'm going to repeat that 3 more times here. She just breathes in. Okay, 1 more time. 5-second traction. Awesome job. Now for the assisted sciatic traction, I would have my patient pull I to S as I push P to A on the spinous. On the spinous is being that we're working on. That's the L4 spinous that we talked about earlier. So that's the one. So as my assistant pulls S to I, I'm pushing P to A as the patient breathes in and out. Now, moving on to our sacral base. What's going to happen here? She is going to let me take a look at this place already. Now, so what's going to happen here is she's going to raise this leg up right here. So raise your leg straight up for me. Just like that. I'm going to push down and she's going to resist into my hand. Okay, relax. Let's do the other side. Raise this leg up as high as you can. Push in my hand. Okay, move back on this side again. One more time. Raise it up. Push. That side is very weak right there. Okay, so that's going to be indicative to a sacral base. Stop. There you go. All right, so now what I'm doing, I'm going to L5 spinous. So there's 4, come down 1, there's 5. What a patient is going to do is she's going to cough. Boom. So my thumb moved towards the ceiling, so that's going to be indicative of a sacral base positive. And the sacral base positive, that shows that the apex has gone posteriorly, so we're going to work on that. If it had been a negative, it would have moved towards her head, and that would be a sacral base posterior. If it was a neutral, it would move up and towards that direction. Okay? So for our blocking for a sacral base positive, we're going to be above the ASIS. So we're going to take this in, there, both sides, here. Okay, so what's going to happen is I'm going to make a contact point on the apex of her sacrum. Okay, so I'm going to put my hand right at the lower part of your sacrum. Is that okay? Okay. So we're here, and what we're going to do is the patient's going to breathe in and out, and as she breathes out, I'm going to push P to A on the apex. Breathe again. Breathe out. Good. One more time. Breathe in. Breathe out. Very nice. Very nice. Okay. If it had been a sacral-based negative, we would just perform that same procedure by pushing P to A on the sacral base as she exhaled. If it was a neutral, we would rock. So as she breathes in, we're going to rock back. As she breathes out, we'll rock forward on that base. And we'll just continue to repeat that process there. Now we'll go back and retest. So she'll raise her leg up again on this side. Very good. You can already tell she's raising the higher. And push, testing it. Still, we had a change, so it went strong. So now we had a very good sacral-based testing. Okay. So let's go ahead and remove these. Awesome, awesome. Okay. So now what we're going to do is I'm going to have the patient sit up and face this wall right here. Okay. Okay. So for our post-blocking, the patient's still complaining of some pain here. So what we're going to do is we're going to go to that L4 spine, so we're having the pain. Okay. So we're here, and what I'm going to do is I'm going to have the patient flex her head, so bring her chin to her chest, and as she does so, she's going to bring her whole back and forward, and she's going to breathe in at that point and push her spine into my hand right here where my thumb is, and I'm going to push simply I to S. Okay. Now the patient's going to breathe out, and as she breathes out, she's going to extend her back but still keep her head tucked into her chin. And as that happens, I'm pushing P to A. We'll repeat that process again. She flexes her spine. I'm now pushing I to S again as she breathes in. Very good. Okay. Now the last portion is going to be, she's still having sciatic pain on her left side, and the spine is rotated towards the left, which is indicative in allowing me to actually perform a side posture adjustment to correct this position. So what she's going to do is she's going to lay on her side. She's going to face the wall right over here. Okay. Okay. And we can rotate. We can walk around over here. So we're looking at this side right over here. Okay. So what we're going to do is we're going to push your hips all the way to the side of the table here, just like this. Good. Good. Straighten the legs for me here. Okay. So we're going to move her into side posture. Just going to hold that right there for me. Very nice. Perfect. Perfect. Okay. So what it is that since that spine is rotated down on this left side right here, on the same side as the sciatic pain, we're going to push P to A on that TVP, which is going to rotate it back into normal position. So I'm put my hip right there. I'm going to fold her over. Well, there was the set. Didn't even need to adjust on that. It's simply just palpate, apply a little pressure, and that was it. She'll face back down again. If there was more restriction, you could perform a P to A chest, but for that patient at that point in time, it went right on set up. We'll palpate the L4 spinous. It's perfect. There's no rotation, no inferiority, and the tenderness, tenderness has gone away? Is it still there? It's gone. It's gone? Tenderness is gone. So that concludes our Cat 3 blocking. Thank you.